Thank you very much, Sarah. And I think Tammy also, as the speakers mentioned, I think this is a fantastic idea. I'm really glad to be here. And I certainly hope this continues on in the future. It's a really important area of research. And I also wanted to comment on the two previous presentations. And I think what you're going to see is actually some overlap between what was two great examples of how this works, and then what my task is today, which is to get into a little more detail in terms of some of the methodological and analytical issues. And I have to say, too, it's a very impressive peanut butter cup that you guys have managed to build there. So, okay, so quick overview of what I'm going to talk about. So I'll talk a little bit about the rationale for integrating neuroimaging with clinical trials. I don't have to say too much about that. Obviously, most of you here believe this is a pretty good idea already. And then I'll talk some more about specific design considerations and analysis considerations, and then talk some about the practical considerations. And you just had a kind of a preview in the discussion a few minutes ago of some of the practical considerations. Okay, so in terms of rationale, why should you consider integrating neuroimaging into your trial? Obviously, one important piece is that then you have a chance to look at the main effect of your treatment on more proximal outcomes. Probably the even more important piece here, though, is it allows you to test putative underlying biological mechanisms of change. That's what we're all, I think, interested in here. And I added a third thing here. I think I'm kind of hoping that that this is translationally hip, and that translationally hip is in vogue right now. Maybe help a little bit on the review process, right? So, so where do you start, and how does this work in practice? And I think you saw some information already about some of this. But the whole point is to identify and test putative neurocognitive mechanisms as mediators of treatment outcome, as mediators between your treatment and behavior change. And so one of the important pieces here, I think, is having a theoretical model. And that's really important in terms of making decisions about how to incorporate neuroimaging into your clinical trial. And so I'm going to try and do in the next few slides is really sort of use an example of a theoretical model that we have been using, and illustrate how it's really important to go back to that model and think about then how do you incorporate, how does that inform your decisions about how to incorporate neuroimaging. Okay, so this is the model that we've been working with, and basically it's, if you go and look at some of the important review papers that have been published the last 5 or 6 years, papers by George Koob and Nora Volkoff and Peter Kalivas and half a dozen other famous people, this is kind of a summary distillation of that. And so what we're talking about here in this model is that heavy alcohol use or relapse after treatment, what comes before that? Well, what comes before that is a strong urge or compulsion to use combined with a lack of control or impaired control. And then working backwards, okay, well, what are some of the neurocognitive mechanisms that are involved in this strong urge or impulse, this compulsion, and this impaired control? And there's a lot of literature suggesting that the executive control network in the brain is important. That gets compromised in alcoholics. And of course, there's a lot of literature both in humans and in rodent models looking at the incentive reward network and suggesting that what happens during the progression of alcohol dependence is that this reward network becomes strengthened. So you get a diminishment of the control network, a strengthening of the reward network, and you get this sort of network imbalance that in theory leads to this strong compulsion plus impaired control. Now, two pieces that we've been very interested in terms of our research is what underlies, in terms of molecular basis, these changes in the control network and changes in the reward network. And so if you look at the literature, especially the animal literature, you'll find some mechanisms there in terms of neurotoxic effects. And what we've been focused on most recently in terms of the reward network is epigenetic regulation. So looking at DNA methylation, particularly with dopamine D2 receptors, and how that relates to this strengthening of the reward network. So I have to say, last night I was at dinner with Tammy and Sarah, and I was telling them I don't have any data slides, and I'm going to feel naked up there with no data slides. So this morning I got up early and I slipped in a couple of data slides. I could not help myself. But I don't have a lot of explanation here, but I'll show you really quickly because we're really excited about this. Epigenetic regulation of the D2 receptor. And so Barbara Weiland, who's supported on the McKay Award, who came to us from Michigan, had been doing some PET studies looking at D2 binding. And we were able to go in and look at epigenetic regulation in the dopamine DRD2 promoter and how it relates to PET to dopamine D2 binding. And what you see here is a very strong relationship in the ventral striatum. The correlation was like 0.7 between epigenetic regulation, we're talking methylation of the DRD2 promoter, and D2 binding potential. So really nice, I think, study there in terms of looking at the potential of this epigenetic biomarker. When we look at the functional data, the fMRI data, what you see here in the left panel is basically any rewarding incentive cue, either juice or alcohol, compared to baseline. Basically what we're finding in our work is that not only does it relate to D2 receptor availability, also relates very strongly to how the brain responds to a reward stimulus. And then interestingly enough, when you look at the, how does alcohol basically activate these striatal areas in comparison to a normal appetitive cue, what you see is it's the negative direction that comes up, especially with the caudate. And so what it suggests here is that this epigenetic regulation, D2 receptor, is very important for responding to reward in general. And what happens is when you have lower methylation levels and you have lower D2 receptor levels, that's when you start seeing the correlation with alcohol sort of taking over that system. And so it actually fits in quite nicely with some work by Neuroimaging and others who have looked at lower levels of D2 receptors and how it's a sort of an important aspect of substance use disorders in general. So here we have this model. We have these biomarkers related to neurocognitive markers. We have these markers we can get from blood, both in terms of epigenetic regulation and in terms of neuroinflammation. And so the question is, how does that fit in terms of a treatment? And so we're looking around for a treatment that might impact on those mechanisms, and particularly interested in psychosocial treatments. And so looking at what's out there, we came up with mindfulness-based relapse prevention. And you may be wondering, well, why that? Well, first of all, a recent study came out showing that, this was like last year or so, a nice bigger study showing that there is some positive effects for mindfulness-based interventions with alcohol. But more importantly, there's been a lot of work on mindfulness-based interventions in the past showing that mindfulness-based interventions, maybe close to a dozen studies now, that they have an impact on inflammatory markers. And even a couple studies in the last couple of years showing that mindfulness-based interventions can change epigenetic regulation. So this is kind of cool because there's a whole other literature out there in terms of mindfulness-based interventions in other disorders and diseases that suggest it has certain biological effects that are now of interest to us because of our theoretical model. Okay, so the question, of course, is, does this intervention have any impact on those mechanisms? What are those mechanisms? And then does that decrease alcohol consumption? So this is the model I'm going to sort of work with to illustrate some of the issues and design considerations in terms of integrating neuroimaging into clinical trials. And it's basically just a more complicated model than the one I showed you earlier, where you've got relapse or alcohol use preceded by this strong urge of compulsion and lack of control. Your control network, incentive reward network. It has these more molecular mechanisms, neuroinflammation and epigenetic regulation. And so the model here is that a mindfulness-based intervention is going to impact neuroinflammation, which impacts the control network, which ultimately impacts alcohol use. Likewise, it may impact epigenetic regulation, which could change the reward network and ultimately impact alcohol use. So what are the design considerations here? So I think the first thing that's important if you're going to integrate neuroimaging into a clinical trial is that you have to realize that all of the normal clinical trial design parameters are going to be in place, right? So typically for the kinds of work that we do, we're talking about randomizing people to a 12-week treatment or a control treatment, then following up with behavioral measures of alcohol use and drug use at 24, 36 weeks, maybe 52 weeks. Sample size, typically if you're dealing with a medium to small effect size, you're looking at 60 people per group. So the bottom line is, you're looking at a study here with all the normal sort of clinical trial design features and 150 to 200 people in your sample. So then how do you incorporate neuroimaging? What are some of the important considerations? One of the first things you have to decide is timing. So when are you going to measure your brain biomarkers? When are you going to measure your brain mechanisms? Are you going to measure, because you're looking at this as a mediating mechanism, are you going to measure it 6 weeks into treatment, 12 weeks or post-treatment or 2 weeks? How does that work, and how do you make that decision? And of course, part of the consideration here is how quickly and how strongly do you expect the treatment to impact the mechanism. So for example, we're finishing up a trial for varenicline in smoking cessation, and we have a scan in the middle there to look at how varenicline might decrease cue-elicited activation in the striatum with smoking cues. And so in that case, actually, we're looking at 2 weeks in, right? Now, in other cases, maybe if you're looking at the effect of a psychotherapy on the immune system or something else, maybe you may go all the way out to 12 weeks, maybe 8 weeks. So again, it depends on your theoretical model and what you think is happening in terms of how the treatment is impacting the mechanism. So some other important issues here is whether or not you do the neuroimaging also at baseline. So you're going to look at change from baseline. Are you going to try and just do it in the middle of the trial? How's that going to work? These are all important pieces, and it really depends on your theoretical model. So again, just to give you a quick example here, in this case, we have kind of 2 different mediating mechanisms. The expectation is that the treatment impacts some inflammatory processes or epigenetic processes, and that in turn impacts the brain network. So in our case, we may want to assess or measure these blood biomarkers at 4 weeks, and then assess the brain biomarkers at 8 weeks, and then the behavioral outcomes at, say, 12 and 24 weeks. So that's just an example of how that might work. So another important decision here is task selection. So what imaging tasks are you going to do, right? And so obviously there again, that's also informed and determined by your theoretical model. So which task best reflects the mechanism of interest, and do you want more than one task per mechanism? So in this case, for example, if you're interested in the control network, maybe you want to look at, for example, resting state connectivity to look at how those important pieces of the executive control network are hooked up. Maybe you also want to do some kind of response inhibition task to see how well people can inhibit a prepotent response. The incentive reward network, there's a number of different tasks you can do to look at reward, MID, you can do some cue-based tasks. And I have to say too, there's also the possibility you can put these 2 things together in terms of both a cue task and a response inhibition task. I'm going to make a plug for my student over here, Hollis. Can you raise your hand? So Hollis is presenting on Sunday, and she's actually presenting a task where we combine response inhibition with alcohol cues. And that's a really nice task too in terms of trying to look at this network imbalance. So, okay, so other design issues. So Kathy actually covered this really nicely. Neuroimaging can complicate sample ascertainment, right? So you're going to have additional exclusionary criteria. You're going to lose people if they had any head injury, and for alcoholics, that's a fair number of people. If they lost consciousness, if they had metal in the body, anxiety about being in closed spaces. So there's a number of ways that you lose people along the way, and you have to factor that in terms of your design. So you also, at the analysis stage, you're going to have some issues that come up in terms of motion and losing people for that reason, or maybe some technical failure in the scanner. And so all these things can impact your sample size and your statistical power. So analysis, a whole nother consideration. And so you understand this immediately if you've been collecting imaging data, because what you get is an exponential increase in the amount of data that you have to deal with, right? And it can become overwhelming very quickly. Another important piece here is type 1 error considerations. So if you're dealing with imaging data, that's obviously there's a lot of potential there for type 1 error. And you have to think carefully about how you're going to reduce the data, how granular do you want your data. And so another important piece here as you're writing these applications and you're doing this work is, there's a whole different type of analysis that takes place in terms of traditional imaging studies versus traditional clinical trials. And so you have to figure out how to put those 2 together in your grant and in the real world. And this is just a quick example. I mean, this is your typical, statistical brain map and analysis, right? And here's maybe your typical clinical trial analysis, right? So you somehow have to get this into parameter estimates that you can get into your model to test your mediation, right? So you have to think about how is that going to work? How are we going to reduce the data, the brain data, in a way that we can get it into our structural equation model and test it, test for mediation. So it requires a little forethought. So some practical considerations, Kathy mentioned this also, the page limits, right? So you're limited in terms of pages, and so just writing up an analysis section for imaging data And you know, the methods, that can take up a lot of space, and that means there's not space for other things, and so it makes it very challenging. And then Kathy also mentioned, you know, you have to think about, am I going to take a few extra hits along the path to getting something funded, take a few more bruises, right? Because you're going to have an expert on neuroimaging as one reviewer, probably an expert in clinical trials as another reviewer, so you've got kind of twice the number of concerns, right, that you might normally get. So, you know, there's going to be a few bumps and bruises along the way. So again, the hope is that you get some bonus points somewhere along the line for being translationally hip. That's the way I look at it anyway. Budget. So budget. Yeah. So, you know, you all know a clinical trial is pretty expensive, more expensive than your typical R01. And a neuroimaging R01 is also more expensive than a typical R01. So you put the two things together, and you know, if your budget was a cat, it would look like this, right? So it's kind of it's difficult to deal with, because then, you know, you're trying to keep the budget down, and you know, times are tough right now, right? So this is an important consideration. Okay, so some final thoughts. I think, you know, pretty clearly in my mind, you know, it's challenging, but it's worth it, and there's definitely value gained by the integration. The mechanisms, I think, it's really important in terms of generating in terms of having the next generation of treatments. You know, we need to do this work. And one thing I want to mention before I turn it over to my colleague Vince Calhoun, new analysis approaches are really important here, because I think, you know, this is a field that's still developing, and analysis approaches are constantly being developed. And the more sophisticated those approaches become, and the more fine-grained, you know, the more we can fine-tune our analyses to look at more subtle changes, that's going to be really important. And I think hopefully Vince is going to talk some about exactly that type of thing. That's kind of his area of expertise. I wanted to sort of tee you up here, Vince. So hopefully that's going to happen. So yeah, so I'm going to stop here and turn it over to Vince.